Ventilation, respiration and breathing mechanics. Ventilation is the movement of air in and out of the lungs. Respiration, on the other hand, is a series of chemical reactions whereby the body converts glucose into energy in the form of ATP. Appreciate this can be in the presence of oxygen, aerobic respiration, or in the absence, anaerobic respiration. Now, the first process of respiration is glycolysis, which occurs in the cytoplasm, and therefore this will happen in both aerobic and anaerobic. Your aerobic yields a far greater amount of ATP than does your anaerobic, 34 in total, using 2 in the first process and therefore yielding a net gain of 32 molecules. Then your breathing mechanics. To appreciate this better, we need to understand the anatomy of the rib cage. 12 pairs of ribs, 24 in total, and anteriorly they attach onto the sternum, the breastbone rather. The breastbone has 3 parts to it: the uppermost, the manubrium, the middle, the sternum, and the bottom, the xiphoid process. The xiphoid process can be located by following the costal margins or the costal arches up here in this way, and there you have over the 2 fingers xiphoid process. This is important because when we perform CPR, we give that 2-finger clearance before applying the thenar and hypothenar eminences onto the sternum or the breastbone itself and perform the CPR. Remember, 5 to 6 centimeters deep. The manubriosternal angle, again, manubrium sternum, manubriosternal angle, angle of Louis. Laterally, you've got second rib, and we use that to find certain bony landmarks in various situations. Posteriorly, the ribs articulate with the thoracic vertebrae. The thoracic vertebrae are different from all the others in that they contain your demifacets. The demifacets are the point of articulation for the rib head, thus forming the costovertebral joint. Remember, the costovertebral joint is actually encapsulated with costovertebral ligaments as well. Don't forget that bit. Move laterally from the rib head and you've got the tubercle around the rib neck, and the posterior aspect of that you've got an articular surface. This is for articulation with the transverse process of the thoracic vertebrae, thus forming the costotransverse joint. Lateral to that you've got the rib angle, and clinically appreciate that rib angle is the weakest point given the mechanics and the physics of the way the rib actually twists as it comes around. It can be classified as a flat bone, and therefore most rib fractures occur at the rib angle, which is more in the posterior region. That's your weakest point. Ribs can be classified as being true, false or floating. Your true ribs are 1 to 7, and the reason they are said to be true is because they articulate onto the sternum via their own costal cartilage. Ribs 8, 9 and 10 attach onto the sternum via costal cartilage, except this is not their own, rather this is that from those ribs above them, i.e. those ribs superior to them. The floating ribs 11 and 12 don't have any anterior attachment at all. The main purpose of the floating ribs is to protect the retroperitoneal organs, particularly the kidneys. In terms of ribs, they can also be classified as typical and atypical. Typical ribs are all those ribs which demonstrate your average bony landmarks. Atypical may have some which are amiss or otherwise have some additional landmarks. I'm not going to go into the details here, rather I'm just going to give you a little memory aid how to remember the numbers. Your atypical ribs are all those ribs which have the digit 1 or 2 in their number, i.e. 1, 2, 10, 11 and 12. The motions of the ribs, there are 4 motions, 3 motions which you need to be very familiar with, and the 4th I think clinically is very important. The 3 motions are your bucket handle motion, your pump handle motion, your bucket handle motion, your caliper motion, and the 4th is your torsion or rotation. Ribs 1 to 6 demonstrate pump handle motion. Pump handle refers to the pump handle on a water pump. So if I move like this, your ribs 1 to 6 will move kind of in that kind of direction, like so, in that way. So they're essentially doing that, just like the pump handle on a water pump. Your bucket handle motion are your ribs 7, 8, 9 and 10, and this is important because they're going to do this. And why? When you perform a respiratory exam, or an A2E examination, amongst other settings, you're going to assess for chest expansion. You're going to place your hands around the costal margin and the lower ribs, and you're going to ask the patient to take a big deep breath in. Anteriorly, if you're doing it from the front, you're going to bring your thumbs like so, and you're going to ask him to breathe, and you're going to watch this move, and what you might find is this one moves but that doesn't, and so on and so forth. So if you can imagine the bucket handle doing this, you'll appreciate this much better, and that's when we denote equal bilateral chest expansion. Your caliper motion, essentially ribs 11 and 12 do this kind of motion because there's no anterior attachment, and then the torsion or rotation is more so around the back. Remember, we said that the ribs articulate with the vertebral body, and in doing so they can't move out of plane, so the only movement that they can do is when we sound out. If I do ribs 1 to 6, if I'm attached posteriorly over here, as the front moves in that direction, the posterior bit is going to rotate about its axis like so, and that rotation is what we refer to as torsion. That's important in the context of trauma particularly, because ribs can sublux. A subluxation by definition is a partial dislocation. Muscles of the rib cage, we've got the diaphragm. The diaphragm largely and mainly is an inspiratory muscle. Depending on what reference you read, 80 to 90% of its function is inspiratory. We have the right diaphragm, the right hemidiaphragm, the left hemidiaphragm connected centrally by the central tendon. It just attaches to the posterior surface of the lower ribs as well as the xiphoid process, and posteriorly attaches onto the lumbar vertebrae, what we call the right crus and the left crus, collectively known as the crura. The right one attaches from L1 to 3, the left L1 to 2, including their intervertebral discs, your IVDs. At rest, the diaphragm is dome-shaped. When it contracts, it flattens. When that happens, the volume of the thoracic cavity increases. Remember, this is the respiratory diaphragm. There are other diaphragms in the body. Now, going on to the breathing mechanics, I need to go through the muscles very briefly. So we've got the intercostalis obliquus externus, intercostalis obliquus internus, and intercostalis innermost. Your innermost complements the work of the obliquus internus. The direction in which these muscles run, your intercostalis obliquus externus, which is the outermost, runs in this direction. Why is that important? Imagine the superior rib, imagine the inferior rib. And it runs from the superior rib to the inferior. And that's important because when it contracts, it's going to pull the inferior rib upwards and outwards. The intercostalis internus run in the opposite direction. So the memory aid for that is placing your hands in your pockets. The other one is internus, and that's my muscles. As I say, mine, it's internal, it's personal, and therefore these muscles run in that way. So your inferior rib and your superior rib. Now remember, we are referring to the uppermost region of the inferior rib, so the superior aspect, and we are referring to the inferior aspect of the superior rib. And when these muscles contract, they'll pull down and in. Okay. Now, when we actually look at breathing mechanics, we have to appreciate pressure gradients. So there's Boyle's law in physics. Boyle's law says, assuming that the temperature is constant, your pressure and volume have an inversely proportional relationship, i.e. when one goes down, the other goes up. Diaphragm, it was dome-shaped, it contracts and it flattens, thoracic volume increases. As the expiratory muscles and the externus, actually the obliquus externus contract, they pull the ribs upwards and outwards. That further increases the volume of the thorax, the thoracic volume. As the thoracic volume increases, the pressure decreases because of that inverse proportionality. The pressure in the thoracic cavity falls below that of the atmospheric pressure. A pressure gradient is formed, and therefore pressure and the air moves down a pressure gradient from the atmosphere into your lungs. Opposite to this, your obliquus externus muscles relax, your diaphragm relaxes, it domes, the ribs move downwards and inwards, the thoracic volume decreases, the pressure increases. Thoracic pressure exceeds that of the atmospheric pressure, pressure gradient formed, and therefore air moves out down a pressure gradient from the thorax into the atmosphere. That's all passive inhalation and exhalation. When we do forced inhalation and exhalation, we actually use some more muscles. And so when we're looking at inhalation, we've got accessory breathing muscles. You've got your sternocleidomastoid, which is this muscle here when you look to the side, so that obvious one here. You've got the scalenes, in your books it says anterior, but there's also medial and posterior. an anterior medial attached to rib 1, posterior attaches to rib 2. These can be involved. You've got your pecs, major and minor, on both sides. So you've got pec major minor here, common tendon here. They are also involved. Your lats involved at the back over here, and you've obviously got the muscles of the rib cage itself. The serratus anterior is another muscle that also gets involved, and that attaches onto kind of all the way down to rib 5 at least, if not, depending on what reference you read. All of these guys become involved and they support that same motion. Whereas when we do forced exhalation, because exhalation primarily is a passive process, no muscles are used when we do passive exhalation. It's just that the muscles switch off. Whereas when we do forced exhalation, what we do is primarily use muscles of the abdomen, and there are four layers of the abdominal wall: your transversus abdominis, your rectus abdominis, your abdominis obliquus externus, and your abdominis obliquus internus. So the outermost is the externus, then you've got the internus, then you've got the transverse. Now appreciate the transverse muscle goes all the way around to the back and it comes around. It's like a tire. That's the tire muscle on your abdominal wall. And your rectus abdominis, it's just literally confined to the front of here. That's your six-pack muscle, which attaches again onto the lower ribs and the costal margins and all that region over here. And you've got the lining albia and the fibrous connections that form the actual six-pack itself. And those muscles are the ones that actually engage in forced expiration, so as to push the diaphragm further up, because you're increasing the abdominal pressure in the abdominal cavity, and because these are both cavities, they've got a reciprocal relationship. When the pressure here increases, to push the diaphragm up and decreasing the volume over here, thus increasing the pressure over here. So there you have it, inhalation, exhalation, breathing mechanics. The rib cage itself. What I didn't mention, one of the things I was going to suggest is cervical rib, just a clinical one here for you before I finish off. Concept of cervical rib. So we've got 12 pairs of ribs on each side, like I said. There is something known as cervical rib. This is not a true rib, rather it is an extension of the C7 transverse processes laterally. And why is that important? Because your brachial plexus, which is a network of nerves that come out from C5 to T1, and they run under the clavicle and over the first rib, a very small space, what we call the thoracic outlet, and they come down into your arm, forming your dermatomes and myotomes. Your cervical rib can actually cause impingement or trouble to the brachial plexus, irritation to that, thus giving you symptoms of thoracic outlet syndrome. And not only do they cause neurological compromise, but they can also cause vascular compromise. Thank you for watching.